dear colleague who is coming from the state, دكتور رامز نادر. رامز يعني من الناس الفيري اكتف اللي كلنا بنفخر بيهم من اول ما كان ريزيدنت. انا فاكر رامز عمل محاضره واحنا في كونفرنس، وكان واحد من الاكسبرتس اللي موجودين. بعد ما رامز خلص المحاضره قال له انا ممكن اخد منك المحاضره دي، وقعد يدسكاس معاه. كان فعلا محاضره رائعه، فيعني بنشكره النهارده على تواجده معانا، وهيكلمنا على الكومبليكيشنز اوف ميكانيكال ثرومبكتومي.
شكرا يا دكتور عمر. And I'll shift gears شوية. I'll talk about the different aspect from thrombectomy, the bad aspect with the complication aspect of thrombectomy. I'd like to thank all my mentors and colleagues. A lot of them are in this room. I'll be showing a few cases, and some of those cases are not actually my cases. A quick background on mechanical thrombectomy. In 2015, mechanical thrombectomy was established as a standard of care for thrombectomies for acute ischemic strokes with large vessel occlusion in the anterior circulation that are presenting within the first 6 hours. Over the next years, the indications were extended to include patients presenting with 6 to 24 hours, anterior and posterior circulation strokes, large core infarcts. The reason for that is the high effectiveness and safety of the procedure, with a number needed to treat of 2 to 5 patients to reach an MRS of less than 2 in 90 days, which is the representative of favorable outcome. However, thrombectomy is not without complications. The most common complication of thrombectomy is symptomatic intracranial hemorrhage and mortality, and studies have reported symptomatic intracranial hemorrhage to be around 5% and can go up to 9% in patients presenting with large infarcts or posterior circulation strokes. Mortality related to the procedure and the natural history of the disease is up 15 to 20%, with posterior circulation strokes that could go up to 37%. Other complications of thrombectomy are either intra-procedure or post-procedure complications. Intra-procedure complications are either related to the general anesthesia use, access site complication, dissection or perforation in the vessels, new or distal territory embolizations, intracranial hemorrhages. And post-procedure could be vessel occlusion, new or recurrent strokes because we can't start anticoagulation right away, intracranial hemorrhage from late hemorrhagic transformation of strokes, iatrogenic pseudoaneurysms, and malignant cerebral edema. I'm going to start showing a case with general complications. This is a 69-year-old patient with past medical history of congestive heart failure and low ejection fraction. The patient presented with an NIH stroke scale of 13, which is consistent with a major stroke. Last known normal was 9 a.m. The patient had imaging which showed an aspect of 10, pretty much no stroke in his, like no detected strokes in his CT. Had a left M2 inferior division occlusion and a mismatch between his core infarct and the ischemic penumbra of 175 ml, which is a very favorable tissue profile. Given that the patient was presenting in the early time window, he received TPA and then was taken for a thrombectomy. You can see here the CT with the hyperdense M2 sign. There's no stroke on the cerebral blood flow volume, and there's a favorable tissue on the Tmax more than 6, which is a favorable number. After the CT, the patient had respiratory failure and pulmonary edema. His EKG showed ST elevation and elevated troponin, which required emergent intubation in the ED. This is the pre and post angiogram. The patient had an inferior division MCA occlusion with one pass tenth aspiration thrombectomy. There was complete recanalization of the MCA, and this happened within 2.5 hours of the patient presentation. However, the post-procedure CT almost showed complete occlusion, like complete infarct in the inferior division of the left MCA on the CT and on the MR. The reason for that infarct progression is probably because of the respiratory and cardiovascular collapse that happened after intubation, which was also exacerbated by the emergent intubation that significantly dropped the patient's blood pressure. So, in general, to avoid those complications, general anesthesia is usually reserved for patients who have airway compromise. Younger patients, because older patients that are more than 80 or 85 years old are relatively harder to extubate. Uncooperative patients who are moving a lot, general anesthesia may be preferable in those patients. And patients who had multiple median or distal vessel occlusions, because those patients we would need better angiograms to be able to do the procedure more safely. And to reduce the risk of intubation, if it's possible to place an A-line during the procedure to monitor the blood pressure continuously rather than using the cuff, and to maintain the systolic blood pressures during intubation to be more than 160 to maintain the collateral and preserve the collaterals and the brain tissue. I'm going to shift to cervical and intracranial vessel wall pathology. This is a case for an 83-year-old patient presenting with hypertension, hyperlipidemia, diabetes. NIH stroke scale on presentation was 18, which is also significant for a major stroke. Last known normal was less than 3 hours from the patient symptom onset. Aspects is 9, which is again a very small hypodensity on the CT, and the patient had a left M1 occlusion. The patient was a candidate for tissue plasminogen activator and then was taken for a stroke thrombectomy. On the first angiogram image, we can see there's an occlusion on the M1 segment with no filling in the MCA territory. The patient underwent 2 passes of thrombectomy that were not successful, so we shifted to a different catheter which has more of a bevel edge that has supposedly better aspiration. During performing the aspiration, there was a dissection in the cervical segment of the internal carotid artery. So we shifted back to using a regular catheter and then advanced the guide catheter over that dissection to keep that intimal flap open during the procedure while reperfusing the inner brain. So did 3 passes, reperfused the MCA, and after that pulled the guide catheter back and left a small wire in the ICA to make sure that the vessel doesn't occlude over time. Kept watching that vessel for 15 to 20 minutes, making sure that it's not occluding, and the vessel kept patent. So at that point we terminated the procedure, and after 24 hours loaded the patient with aspirin, and the patient was kept on aspirin for 6 months. With regular follow-up imaging, this patient did not require stenting. It's another case for intracranial dissection. This is a 66-year-old patient with pathological history of hyperlipidemia, diabetes, had a recent stroke and was on dual antiplatelet. The patient presented with an NIH stroke scale of 11, last known normal of 12 hours, which is a wake-up stroke. His imaging showed an aspect of 6 to 7 and a right M1 occlusion. He had a mismatch of around 88 ml, which is a significant favorable tissue profile. Given the late presentation, the patient was not a candidate for thrombectomy, for TPA, and then was taken emergently for thrombectomy. As you can see here, there's a small hypodensity in the right subinsular region, and there's attenuation in the M1 segment. On the CBF, we don't see a large core infarct, but we see a huge perfusion mismatch with a large ischemic penumbra on the Tmax more than 6. And this is the pre-procedure, like the first angiogram. There's an occlusion of the M1 segment with no filling in the MCA territory. Patient underwent 2 passes of stent retriever thrombectomy. The first pass showed partial recanalization, and the second pass showed complete recanalization of the territory. But then, over the next few minutes, the patient was having progressive occlusion in his MCA, and you can see the narrowing here in the MCA getting progressive, and there's flow limitation, which suggested a possible dissection or a possible underlying intracranial atherosclerotic disease. So this patient had a previous stroke. He was already on aspirin and clopidogrel, which is the second dual antiplatelet. And ended up having to stent with a wingspan stent, a 3 by 20 millimeter stent in the MCA to keep that MCA territory patent. Post-procedure CT showed a small hypodensity in the right MCA territory, and he had a stroke which is pretty much similar to what he had on his initial CBF imaging less than 30. So he didn't have an expansion of the stroke, but given that the stroke was happening in an eloquent area, the patient ended up having a slightly bad outcome with an MRS of 3 at 90 days. So those cases of refractory thrombectomy where even after performing the thrombectomy, the vessel either re-occludes or is not able to open, is not uncommon, and they happen between 8 to 15% of the patients. And it's most commonly due to intracranial atherosclerotic disease, but could also happen due to dissection or calcium emboli. Those patients, if successfully recanalized, usually have achieved good functional outcomes, and the use of glycoprotein 2B3 inhibitors or intracranial stenting is relatively safe and effective in those patients. With 50% of the dissection and ICAT patients usually require stenting, and most of the patients who have the calcific emboli would eventually require stenting. The use of angioplasty alone with angioplasting the artery with a balloon is usually not effective, and the majority of the time would require rescue stenting. Now move to another case of vessel perforation. This is a 58-year-old patient with past medical history of coronary artery disease, AFib, obesity, COPD, drug abuse, presented with endocarditis, and underwent a STEMI and cardiac stenting, and was on IV cannabidiol, which is another PTY12 inhibitor, similar to Plavix. The patient presented with an NIH stroke scale of 15 and last known normal of 12 hours. He had a relatively large stroke with a very low aspect score, but at that time, that patient was randomized to a multi-center study and was randomized for thrombectomy. You can see here there's initially a large hypodensity in the right MCA territory in the insular and the subinsular region with an occlusion of the M1 segment of the MCA. You can see after the first pass of thrombectomy, there's recanalization of the vessel, but we can see some extravasation in the MCA territory over here. So at that point, the guide catheter was advanced distally to help in arresting the flow, and the balloon was taken to the MCA and inflated and kept inflated in the MCA for 20 minutes while the blood pressure was being dropped by the anesthesia team, and the patient received some medications to lower his intracranial pressure. After 30 minutes, a repeat angiogram was performed, and there was no evidence of any residual extravasation, and the vessel was left occluded at that point because recanalizing the vessel could lead to another attack of hemorrhage. This was the post-procedure CT, so dual energy CT, in the image on the left with the 80 kV that basically shows some of the contrast staining and some of the hemorrhage, but the 150 kV images are more sensitive to the hemorrhage, so it's a mix between some contrast staining from that perforation and some subarachnoid hemorrhage. After 6 hours, the patient hematoma expanded, he had a lot of mass effect, and eventually the patient had subfalcine herniation and died within a month. This is another case of vessel perforation in a 91-year-old patient who had a medical history of TIAs and strokes, hypertension, hyperlipidemia, and presenting with a chronic left ICA occlusion. A very high NIH stroke scale, again significant for a major stroke. Last known normal was 4 hours. At that time, the patient didn't show early signs of infarct in his CT, but he had a cervical ICA occlusion. He had multiple A2 and A3 occlusions, multiple M2 and M3 occlusions. He had a large core infarct on the perfusion imaging, even though it wasn't showing on the CT. Patient received tenecteplase and was transferred for thrombectomy. So we can see here almost both cerebral hemispheres have perfusion deficits due to the chronic occlusion on the left side, and there's acute occlusion on the right side, which is also basically causing that stroke on the right side. So we use the balloon guide catheter to recanalize the proximal aspect of the cervical ICA, and then we tackle the intracranial aspect afterwards. And after one pass of centrotubular aspiration thrombectomy, the patient had a TK2A with partial recanalization of the right MCA territory. But at that time, the patient still had residual occlusion in his A1 segment and residual occlusion in 2 of the MCA branches. So we did multiple passes to recanalize the ACA, and while trying to put a microcatheter in the MCA, we can see some contrast extravasating here. Okay. At this point, we advanced the aspiration catheter into the superior division and coiled off that branch of the MCA to stop the bleeding. So eventually, the patient had reperfusion of the ACA, but with residual occlusion in the MCA territory, and reperfusion of the proximal cervical ICA. Post-procedure CT showed a mix of contrast staining and hemorrhage. On the dual energy, it's the majority of the hyperdensity is from contrast staining, but the patient eventually had a large infarct given the large territory that was not perfused, and the patient ended up having family elected for palliative care, and the patient ended up dying. So in cases where there's vessel perforation, in order to avoid that, early recognition is the key to start with early intervention to prevent progression of that disease. Having coils and balloons readily available, even for thrombectomy cases, is very important. It could be life-saving. A good anesthesia team that could drop the blood pressure, start some medications to reverse the heparin, and at the same time start hyperventilation to lower the ICP is always important in those cases. Distal occlusion are better performed under general anesthesia to avoid perforation in the vessels. And large stent retrievers, which are like 6 millimeter, should be relatively not used in distal vessels like the M2s and M3. And if a vessel gets occluded, if the patient has hemorrhage during recanalization of the vessel, it's sometimes better to keep those vessels occluded to prevent reperfusion hemorrhage. This is another case of a 72-year-old patient with hypertension, hyperlipidemia, diabetes, who had a aortic valve stenosis, underwent AV valve replacement, and was placed on warfarin. The patient presented with an NIH stroke scale of 15 for a left M2 occlusion, was coming within the first 6 hours, relatively small infarct with a large mismatch volumes around 44 millimeters in the brain. The patient was not an IV TPA candidate because he was on warfarin, and then was transferred for a stroke thrombectomy. As you can see here, there's a favorable position profile in the left MCA. The patient had a bovine arch. We ended up doing the procedures through his wrist, and did one pass of stent retriever aspiration thrombectomy, recanalized part of the artery except for distal occlusion in his MCA in an M4 branch. The post-procedure CT showed a relatively favorable outcome. The patient had minimal contrast staining with almost no subarachnoid hemorrhage, and given the small occlusion in the M4 branch, we kept the patient's blood pressure a little bit higher and allowed it to go up to 160. However, within 24 hours, the patient ended up having a subarachnoid hemorrhage and a parenchymal hematoma. Still at that time, the patient's NIH stroke scale was relatively improving, but over 30 days, that hemorrhage expanded, and the patient ended up having a subfalcine herniation and dying. This is the last case of a 46-year-old patient who had a past medical history of hypertension, hyperlipidemia, MI, drug abuse. He presented with an NIH stroke scale of 12, which is also consistent with a major stroke. Last known normal of less than 3 hours. Patient had a left M1 occlusion in aspects of 10. Had no CTP because he was presenting early in that time window. Was not a candidate of TPA, but was transferred for a thrombectomy. As you can see here, the patient had a left MCA occlusion. Following one pass, there's partial recanalization of that left M1 segment, but the patient had residual occlusion in his M2s and bilateral A2, A3 occlusions. Trying to recanalize that MCA, eventually after performing multiple passes, we were able to open up the MCA and the ACA with a small residual occlusion in some of the distal branches of the ACA. However, given the number of passes and putting a stent in distal vessels multiple times, the patient had a large amount of hyperdensity on the CT afterwards, which is responsive to contrast staining with some subarachnoid hemorrhage, and has some early hemorrhagic transformation in his basal ganglia. Over the next 24 hours, the patient's infarct expanded and the hemorrhagic transformation became larger. The patient had a hemicraniectomy to help relieve the mass pressure, but again, the patient ended up dying. So in conclusion, even though mechanical thrombectomy is one of the most powerful treatments in medicine with a very high number needed to treat, the procedure is not without complications. Some of those complications could be avoided and some of them could not be avoided. Like with general anesthesia, like right patient selection could help avoid those complications. In cases of refractory thrombectomy, using antiplatelets and stenting could be favorable in some patients. Vessel perforation is usually associated with poor prognosis, even if everything was done. And reperfusion and infarct transformation can sometimes be avoided by lowering the blood pressure, but it's more commonly happening when patients who present with a large core infarct or the systolic blood pressure is kept liberated after the procedure. Thank you.
شكرا رامز على المحاضرة الجميلة دي. انت بتطمنا الكومبليكيشنز اللي حصلت في امريكا بقى؟
دي كلها حصلت هناك.
مش وحشين يعني هنا في مصر؟
لا مش وحشين خالص. مش وحشين خالص.
ازاي نافويد، يعني انت برضه شايف شغلك افويدنج الكومبليكيشنز بتحصل بروسيدوس سيربرال هيموريدج برفوريشن، عايزين كنت تدينا مثلا الحاجات اللي نخلي بالنا واحنا شغالين لليونج دكتورز كده.
في حاجات you can avoid وفي حاجات you can't. يعني الحاجات الانستيجيا مثلا you can avoid by لو تقدر تعمل انستيجيا يبقى في تيم يبقى تريند وتبقى مديهم انستراكشنز من الاول ان هم not to lower the blood pressure قوي عشان to maintain the collaterals. فعيانين اللي يحصل عندهم perforation يعني لو في جنرال انستيجيا في الاول وقادر تعمل procedure on the road map ده هيقلل الفرص ان يحصل perforation. بس هو لو حصل perforation everybody is liable to يحصل perforation. There's no way you'll have to occlude that artery and the patient will end up having a bad outcome most of the time. Patient selection. العيانين اللي بيبقى عندهم large infarcts من الأول they're more likely to have hemorrhagic transformation so that should be expected. فلو مفيش ICU team أو مفيش availability ICU كويسة بعد كده ده هيبقى صعب. العيانين دول مش يعني less common إن هم يتعملوا لو مفيش available ICU كويس بعد كده. it's more of patient selection والteams اللي موجودين شغالين معاك. بس في complications are non-avoidable للأسف.
طيب اللي بيعمل ثرومبكتومي بيبقى نيورو انترفنشن ولا نيورولوجي ولا يعني في ناس دلوقتي يقول لك هنعمل ثرومبكتومي بس اتعلم ثرومبكتومي ما عندوش باك جراوند للنيورو انترفنشن. واحنا شايفين كده، انا شايف من كلامك ان لازم اكون عارف اتصرف، عامل كويلنج مثلا لو ارتري حصل رابشرز
يعني على حسب البلد يعني البلد السيستم بتاعها ايه. يعني هنا احنا في ناس نيورولوجي ونيوروسيرجري بيشتغلوا، امريكا في نيورولوجي ونيوروسيرجري بيشتغلوا. بس هو الشرط هناك ان عشان اي حد يعمل البروسيجر لازم يكون على الاقل خد 2 سنين تريننج وخد سيرتيفيكيشن عشان يقدر يشتغل بروسيجرز. ما ينفعش ان حد يجي يقرر ان هو النهارده هيروح يشتغل ويعمل ثرومبكتومي يروح يعمل ثرومبكتومي. وحتى الان مفيش سيستم ليست في امريكا ان حد يعمل ثرومبكتومي بس وما يعملش بقيه الحاجات. لو حد هيبقى ترين في نيورو انترفنشن هيعمل كل حاجه عشان لو حصل كومبليكيشن يعرف ان هو يتعامل معاها.
شكرا يا رامز. في اي اسئله رامز؟
بس هو في نقطه بس عايز اقولها يمكن to avoid the